Good morning, everyone. My name is André Baruchel. I'm a pediatric hematologist and professor of pediatrics in Paris, University Hospital Robert-Debré in Paris, France. And I'm a specialist in acute leukemias in children. So I have been asked today to talk about the possibility of relapse. When a diagnosis and a first-line treatment of acute lymphoblastic leukemia is made, obviously, we cannot cure or cannot assure that we cure all children, adolescents, or adults at the first attempt, which means that after a first remission, sometimes the disease can come back. The question when comes a relapse is, when are we certain that this is a relapse? So we convene a group called Ponte di Legno some years ago in 2021 to agree on both sides of the Atlantic on what is a relapse. The old definition was to say, if by a bone marrow puncture I find more than 25% of cells leukemic blasts, then it is a relapse. Now that we have much smarter techniques, much more sensitive techniques, the threshold has been diminished to 1% if this threshold is determined with very sensitive techniques called molecular techniques or flow cytometry techniques. I will not enter into detail here. So let's assume that there is a relapse. Where can the relapse come? The question is, it can come everywhere, basically in the body, but as the main source of leukemia is in the marrow, generally, most of the relapse comes back to the marrow. The other sites where it can come either in an isolated way or combined with the marrow relapse are the sites that we try to treat very intensively in first line, which are the CNS, the meninges, which are packing the brain and the medulla, and the testis in boys can be a site of relapse, and also very rare more sites like, for example, skin or mediastinum or other places in the body. But let's concentrate on marrow relapse, which is the more frequent occurrence of the relapse. So generally, it's not good news, neither for parents, for children, for adolescents, for adults. It's very bad news because it means that we need to come back with very intensive treatment. So what kind of treatment do we have on the table now? We have a lot of possibilities to cure, even at the second attempt, the disease. First, when the relapse comes late in our language means more than 30 months after the diagnosis, because the first-line treatment generally has a duration of 24 months, and the 30 months correspond to children who do not relapse during those 24 months, plus 6 months after stopping of the treatment. So let's talk about late relapse, which are representing approximately 20-30% of the cases. Those late relapses can be cured with, let's say, classical treatment, including chemotherapy and sometimes radiotherapy if the CNS is involved. And now has come the idea that we can also add the blinatumomab, which is a bispecific antibody, which can help to treat the disease. At the contrary, when the relapse comes early, below this 30 months threshold, then the situation is more aggressive, and it's generally recognized that you need more intensive treatment, and maybe you need more than chemotherapy plus immunotherapy. You will need sometimes bone marrow transplants. So the question is, if we want to go to transplant, we need to have a very low level of disease. And to come to this very low level of disease, there are many possibilities. Now we have obviously intensive chemotherapy, but some patients are refractory to this intensive chemotherapy. We have these monoclonal antibodies which are bind to some kind of explosives called chemotherapy targeted by antibody called antibody drug conjugate. And we have a very specific one called inotuzumab. This inotuzumab recognizes on blast a motif called CD22, and the antibody sticks to the leukemic cells, and the grenade, which is at the bottom of the antibody, penetrates inside the cells and kills the cells. So for refractory to chemotherapy patients, we can use these new agents. And then, as soon as the disease has diminished, we can come with a bispecific I alluded to called blinatumomab and reduce again the disease. So blinatumomab helps a T cell, which is a lymphocyte that everybody has in his body. These T lymphocytes do not see well the leukemic blast. But if you show them the way with this antibody, then the antibody will bring together the leukemic blast and the T cell, and the T cell will kill the leukemic blast. But when there is too many blasts, it doesn't work. But when the blast volume has been reduced previously by chemo or inotuzumab, then the blinatumomab is a very, very powerful weapon. And when the disease is not detectable after those blinatumomab treatments, then you are in the best situation for a very aggressive treatment called bone marrow transplant. Bone marrow transplant is not a surgery. It is an infusion of stem cells which have been taken in someone else. Someone else could be a related brother or sister, which have the same typing in the white blood cell called HLA typing, which resembles the one of the recipient. It can be sometimes bone marrow donor bank. It can be sometimes a cord blood from bank. These are different sources of hematopoietic stem cells which can be used. So you do not make a transplant just by infusing the cell. You make a transplant because you will deplete the bone marrow of the recipient by giving radiotherapy, unfortunately, on all the body. It's called total body irradiation, plus chemotherapy. And then you infuse, after a few days, you infuse the hematopoietic stem cells, which is a kind of a bag of blood, finally. This takes approximately 1 month for the new cells to be amplified and to reconstitute the normal counts in the blood, which are, for example, 5,000 white blood cells per microliter, 10 to 15 gram per deciliter of hemoglobin, and more than 100,000 platelets, for example. But you have transplanted a new immune system, and this immune system can kill the leukemic cells which are potentially still present in the body of the child or adolescent or adult. So this is the good part of the transplant, that there is an immune effect which can kill the leukemic cells. The dark side of the force, if I can say like this, is that these cells also recognize as foreigners the rest of the organism, the rest of the body. And this can cause a disease called graft versus host disease, GVHD. And this GVH can aggress the skin, which is kind of being red. give high fever, but more importantly, can aggress intestine, give a lot of diarrhea, and can aggress the lungs, can give sometimes difficult to breathe, and also can aggress the liver. So this is a reaction that we try to prevent with some drugs like cyclosporine and methotrexate and others, but sometimes it happens. So when it happens, we have steroids, and now we have new agents that called JAK inhibitors. We have other agents which can help to combat this GVH. And from acute GVH, sometimes patients will develop so-called chronic GVH, and for that also now we have more effective treatments, but it's a disease which can unfortunately last for a very long time. So transplant is still a big adventure on the medical point of view, and you can assume that after transplant, the majority of the kids will be cured, but not all the children can come to transplant. And also, because of the total body irradiation, you can have sequelae after transplant. The first one being infertility, but others could be secondary cancers and problems for secreting normal level of hormones in women or in males that we can substitute with obviously drugs, specific hormones. But anyway, it means that transplant is not an easy treatment. So the trend is to try to replace transplant. We are not that yet, but there are very interesting hints on the table. And the major one has been introduced in a clinical trial approximately 10 years ago. The trial has been published in 2018, called Eliana, the name of the trial. And this trial has allowed the doctors to infuse to the children genetically modified T cells, which have been taken from the body of the child. So this extraordinary adventure has begun in 1989 at the lab level, and unfortunately the inventor called Zeli Gesha just died a few days ago in August 2025. And Zeli gets the idea to transform a T lymphocyte to a chimera to give them a real new weapon on the surface derived from a B cell. So it's kind of mixing a B cell and a T cell. It's more complicated than this, but for today it's enough. So you take blood at the moment of relapse or after, if the relapse doesn't respond well. You take blood from the child or the adolescent or the adult in B lymphoblastic leukemia. This doesn't work yet very well for T cell, but for B cell acute lymphoblastic leukemia, you take blood from the child on a machine which is a kind of a centrifuge. So you take only the white blood cell, which are the T cell. And then those T cells, you will grow them in vitro with a virus, which is a cousin of HIV virus, but not dangerous. And this virus contains a new cassette for expressing a new gene in the T cell. So the virus enters the T cells, go into the DNA of the T cell, and will begin to play a new music on the surface of the T cell, which is a new weapon. And this weapon has been designed to recognize a motif on the leukemic blast called, for example, CD19, which is the same target for the blinatumomab. And this CD19, when the T cell recognizes it with this new weapon, they activate, they begin angry, if you will, and they begin to proliferate, and they kill the leukemic blast. And this seems science fiction, but the very first child have been infused in 2012. And we know the name of the child because now she's very famous. Her name is Emily Whitehead. She has been infused in Philadelphia in April 2012. And today she's going to college. And she was a 9-year-old girl at that time. So the fact that Emily went well was a very big hope for other children in the world. And that fantastic trial, which have been open in 2015 and published in 2018, Eliana has reported that with a transcontinental trial, you could produce for each child, nearly each, because sometimes there are manufacturing problems, but for nearly each child, you can produce genetically modified T cells, which can recognize its own leukemic cells and kill them. And this is much more simple to administrate that transplant, except in the very first day, because before giving those CAR T cells, CAR means a strange name, chimeric antigen receptor T cells, let's call them CAR. So those CAR T cells, you need, before infusing them, to make a so-called lymphodepletion, which means that you want to deplete the lymphocytes in the body of the child or the adolescent. And this lymphodepleting chemotherapy is a kind of chemotherapy which is not so intensive. For example, some children do not lose the hair. So after a few days of chemo, you infuse the T cell, and then comes the problem, because there are a mass of leukemic blasts in the body, and there is a combat between those very equipped T cell, very smart, if you want, very aggressive, and the leukemic blast. And this combat gives a very high fever, can give hypotension, and can bring the child or the adult or the AYA to intensive care unit for a few days. Fortunately, very severe reactions now are very rare. At the beginning of this technique, 50% were going to ICU. Now the percentage is in the range of 10 to 15% in most of the unit, because we know how to manage this kind of patient very well. We have extremely powerful tools to pass this, let's call a very severe flu, if you want. So after a few days, the child begin to feel well, the counts in blood recover, and generally after 2 weeks, the children are out. And after 1 month only, you can see the complete remission comes back. And this is extraordinary, because only one infusion of cells can clear a disease. And of course, we monitor this patient very closely. And now we have patients with 10 years of follow-up, more than 10 years of follow-up, who are cured. So the question is that the marketing authorization at the moment is not for first relapse. The marketing authorization is for second relapse, first relapse after transplant, if some children have relapsed after a transplant made in first line, or if the first relapse is not sensitive enough to the treatment I referred to at the beginning, chemotherapy or immunotherapy. So if you have a disease which resists, this is a good candidate for CAR T-cell. So the hope that we have is that the CAR T-cell will be given earlier in the lines of leukemia. And we hope that with those CAR T-cells and with the other ways of giving immunotherapy, we can cure most of the children when they relapse. We must recognize that, one, we cure at the first attempt 85% of the children, approximately 75% of the adolescents, and probably less for older adults. But in these 15% in children who relapse, we can save now more than 50% overall by those fancy techniques. So which means that the overall survival, which is the survival of kids, whatever they have been cured at the first attempt or a second attempt, now in most of the privileged country is above 92, 93%. So we can have a great hope for children with acute lymphoblastic leukemia. The prognosis is also improving for adolescents and adults. And I would say that we have every 5 years new weapons, and the hope is great that one day we will cure every patient with acute lymphoblastic leukemia. Thank you very much for your attention.